doing things. I'll meet her.
Okay, we're going to get started with the last session. Glad you're all hanging in there. This is wonderful. Just logistics first. Your certificates will be in downstairs back on the ground floor. PT might be right at the elevator, and then the others will be down where you got your lunch stuff and refreshment breaks, but they'll be on that floor. Try not to exit from this floor, even if you're leaving early, because you don't have to be able to get out the building. Okay? You have to go down to you can go out either way, and then we're going to monitor the doors at the end of the day and stand there and open it for you with our IDs.
So it's toward the garage.
To the garage.
To the parking garage.
You can go out the sides, but if you want to get to the parking garage, we have to have an ID to get you out. You can get in, but you can't get out. Don't answer. And the fire hazard, does this make sense? No, but, and they were asked to open the doors, but they're not. So first, second, or third floor to exit. Certificates of completion will be in the basement, and that's the logistics. There's also a bathroom right here, so you don't have to go traveling. So I want to welcome you to our last section. Dr. Catherine Gohrband is going to be presenting on a topic near and dear to her heart, having to do with older teens and adolescents and that transition of service delivery. As you know, maternal and child health has a very, very big initiative on this topic right now. This is a very underserved topic that is the essence of Dr. Gohrband's PhD work right now at UK. So this is what we always let our doctoral students share their passion with you, and this is a topic she's passionate about.
I am. Thank you. Thanks, Susan. Thanks to you and the Prepare Committee for giving me this opportunity to speak. And thanks again for sticking it out to the very end. So what I want to know is kind of who you are. We talked about earlier today, are you PT or an OT or speech? But what I want to know is, how many of you see adolescents on your caseload? Good. How many of you help with some transitions for those adolescents from school to maybe the next therapy setting? A few less. Okay. And that's what my topic is for my dissertation, but I'm going to kind of use some of that as a segue for what we're talking about today. It is, we all went into pediatrics, and when we did that, most of us didn't really think about those kids that look more like adults, right? We thought about those little kids and how cute that was going to be, and we're going to make such great gains. We were going to teach them to crawl and to walk, and then all of a sudden, as we follow them on our caseload year after year, their bodies become bigger, they become older, and all of a sudden they're teenagers, right? So it requires a little different shift in focus. Okay. So here my objectives are. I'm going to back up a little bit. I want to talk about some of the changes that happen as children age, and especially as this population of kids with lifelong disabilities age. I want to talk about the changes that happen in their activity and participation levels, the status of their physical abilities, and appropriate expectations for therapy. And finally, I want to talk about some expectations for therapy and maybe some meaningful interventions that we can use with this population. I don't have my interventions specifically divided up between PT and OT because sometimes by this point we're working together on the same thing, right? So, and you'll see that as we continue to talk more. One of the things we're going to do is you're going to hear me talk about geriatrics. It's like, we didn't sign up to talk about geriatrics. We're pediatric therapists. But we're going to need to talk a little bit about that to come back to the middle, okay, with all this. So I want you to know a little bit about me and where I came in this journey so that this makes sense. I was born into a family with a grandmother who was a special ed teacher and went back to school to get her master's in the 50s, and I had an aunt who had Down syndrome. Okay, so I spent my entire life with this population, and my grandma at that time was really progressive. They helped to start the Association for Retarded Citizens, which we don't use that terminology anymore. And also, they developed a camp for young adults with disabilities. So they were real go-getters. My aunt she was born at the end of World War II. So at that time, when you think of it, the country was involved with the war effort. They kind of looked at my grandparents, whose names, by the way, were George and Martha, no relation to the Founding Fathers. But, and they kind of told them, oh, you know, we're sorry about Elizabeth, and maybe we can help you find a good place to put her, right? So the world has dramatically changed since that time, and it's been kind of fun as a family member to see that. So I went to PT school. I was not going to be a teacher like my mom, and I was not going to be involved in special ed like my grandma because I was my own person. And I went into PT, and I was not going to see kids, right? And guess what happened? All three of those things. Your genetics, I think, kind of follow you. So as I've been a pediatric therapist for a long time, one of the things that happen, like Lori said this morning, is you have kids on your caseload that you tend to follow and you get attached to. And you just don't get rid of them because they're getting old. That would be, we just don't toss them off, right? So you get attached to them. You know their families, you know about them, and then you start to realize that they have some different needs as they get older. And you start to see some things emerging. You know them, and you get a little crabby about those people on the team that are new to your team that want to make judgments about them that maybe aren't accurate for those kids, right? Because you know them so well. So there's a couple things that happen, right? And we all have great stories, but one of my best stories that kind of illustrates this is that I have a friend who I followed for a long time. She is very ataxic. She is needs a lot of assistance to move around, and because she's ataxic, she doesn't test well on cognitive scales because of her verbal skills, right? Can you picture her? And she's placed in a classroom that is with kids that are much lower functioning than she is, okay? So she would come to therapy and tell me things like, it's okay that I'm late, you know, they're watching SpongeBob and kind of done with SpongeBob, and, you know, so she can verbalize that. But she has some normal age-appropriate interests. But because she can't do a whole lot, her normal age-appropriate interests sometimes get her into trouble, right? She loves to text. So in the summer, when she's bored and her mom is having a garage sale and she doesn't have much to do, she texted her teacher that there was a fire and her mom wasn't home. She was lonely and she wanted to see her teacher. So guess what happened? The teacher came running over to make sure she was okay, and that was just so fine, right? So the other thing that happens, I think, is as you have kids that have been on your caseload and they age out of school or they age out of services in school, right, because they're getting older, you see them in a little bit different light, or they contact you back and say, hey, I'm having these issues with pain, or I'm not walking as well as I did, or I really would like to try some different exercises. Can you help me? And because of your setting, maybe you can't, and you would love to refer them somewhere, but sometimes there isn't that place to refer them to. And so, in a way, we feel like a lot of our population kind of falls off the edge of the cliff with that, don't they? So I decided, after a long career in PT, to come back to schools, which proves that you can learn at any age, right? So I did part of my studying at a part of UK called the Human Development Institute, and in that I decided to do a project where I was thinking about this population and what do we do with them? You know, how do we manage them? So I did a pilot study of a survey of 70 of my best friends in Dayton who were school-based therapists, and I got really great returns because I did a survey and stood by the door and asked for them to put it in my box as they left. It was a great way to get a good return. And what I found was, hey, it's a great idea. Someone needs to think about what should happen with these students, but we don't know because we don't do it because in school, a lot of times either they're out of school or if they're still in school, we can't justify our services anymore on the IEP. So, and that may have just been that particular school district. You know, there was a lot of conversation about, you know, what's the difference between real life practice and what the law actually says. A lot of people felt their hands were tied with how they dealt with that population. So that is kind of the gist of why I got involved with this, because at some point someone needs to figure out what to do with this population. The medical field is a little further ahead than we are. There's some mandates for primary care pediatricians that they're looking at who should get these kids as they age out next and what should be done with them. But we still have kind of a hole with that at this point. Okay. So to start at the beginning, this is what we're really familiar with, okay? When we're seeing kids and we're looking at developmental assessments, usually that 0 to 2 years is most often on our mind, isn't it? Okay, especially if we deal with younger kids. Where are they on that scale? When you went to school, we talked about those, learning those developmental milestones, and usually we kind of stopped at about 2 with what we knew month by month, okay? And sometimes we had considerations up to the age of 7, because by 7, most of our systems are kind of more adult-like, right? We don't really say, oh, what's the difference in skill development from 7 years to 9 years? Right? Everything kind of stops at 7, and you even see that in a lot of our assessments where the ceiling for that assessment is 7 years or 7.5 years. Okay? So by 7, you have proficiency at all those things that we consider functional, like walking, running, jumping, being able to throw, holding a pencil, dressing. You're pretty good at that. And for a lot of years, I think we've thought that must be good enough. You're functional. Right, if you can do those things. But I want you to look at another set of expectations, and this blends beautifully into what Lori said in actually some of both her presentations today. So if we look at the idea of, so what? They have all these skills, now what can they do with them in life? Okay? We need to know things like the development of meaningful hobbies starts to happen with higher levels of fine motor skills at about 9 years. When you think about what your 9-year-old can do, okay? Running speed stabilizes first in girls, then in boys, okay? You tend to seek emotional autonomy from your parents at 14 years, so you either remember that or you have kids that are reminding you of that. Is that right? No. The standing long jump distance either stabilizes or increases at about 14 years. You reach your fastest reaction times at age 15, which makes sense about why driving starts after that, doesn't it? With that, you're seeking out relationships and friendships at about 15 years, okay? And so that doesn't have much to do on, if we looked at it purely on paper with PT and OT, but based on what we heard this morning, doesn't it say everything about this population? And we're wanting them to engage, okay? So we need to be aware of some of those things, that they are in adolescence at a peak age to have some say in what's happening with them, to have more self-determination, and to have more of a peer-to-peer, team member-to-team member relationship with us as we're planning for their interventions. A lot of kids reach peak performance level in sports by 16 years, and many of our kids won't reach that. But it's kind of good to know in the back of your mind, okay? And they're actively in search for personal identities by 16 years, okay? And that's where Lori was talking about some of her measures of participation in the last session, and she talked about really looking at those quality of life measures and what do you want to do. Those measures are what gives kids the voice to help say what they want and to really cement in their own identity instead of them taking on the identity that we kind of bestow on them. So some of the things that contribute to development, okay, that we know, you have to have an intact sensory system, motor coordination, balance, strength, development to be adaptable in your behaviors, and cognition, right? And we really look at lots of assessments as a team with the kids that we evaluate and treat, and we kind of know what areas they're not doing as well at, or what areas are holding them back at, okay? So if we flip the mirror and look as we all get older, the decline in these systems are what causes us to decline in our function, okay? So we build it up on one end, and then we're ramping it down on the other end. So in the normal aging process, we see that general decline, okay, in sensory and motor processes. And we're dealing with a population of students that often don't have intact processes to begin with, okay? In our older population right now, we know there's a greater range of variability. So, for example, if you're 80, you don't look the same as other 80-year-olds, okay? So you can have, in this, you can have a range from people in their 80s who are very physically debilitated and dependent to people who are competing in the Senior Olympics. And they may have the same date of birth, okay? But how similar is that to a lot of the kids that we see. If you pick one age, the variability in function is so great. So as we're talking about adolescents with lifelong disabilities, it isn't a one-size-fits-all. It still is that whole individual, looking at them as an individual. And they have a lot of ranges of ability. Okay? So I'm going to take you back to normal development in terms of geriatrics, and we're going to overlay that with some things that apply to our population. Okay? So in terms of our cardiopulmonary system, would you agree, and we can see that changes in people's cardiopulmonary health starts to decline between your 4th and 7th decade. Okay, but a lot of functional deficits aren't really evident till you're in your 70s or 80s, right? So if you do any moonlighting in an acute care hospital or have older relatives, you start to see in their 70s, it isn't uncommon for people to start having some cardiac issues, right? Okay, and sometimes now we're looking at, is that just because you're aging or is that because of deconditioning? And it can be a combination of both. So when you look at our population, you know, we thought it was so great that they could walk independently. We make sure they have some form of independent mobility, but we really haven't been able to capture maximizing their cardiopulmonary system in a lot of cases. Okay, unless right now they're fairly close to typical development. Okay, so in our population, okay, their diagnosis, a lot of times, if they have a primary cardiopulmonary diagnosis, they may have passed away by this time. So I'm thinking of people that, if you have an older patient that has Down syndrome, a lot of times they didn't have the technology way back then to be so in tune with addressing heart defects. Okay, if you have a lot of times people with muscular dystrophy passed away much earlier, cystic fibrosis. We've come a real long way, haven't we, in improving their lifespan. In terms of the integumentary system, in our typical population, our skin becomes thinner as we age. Okay, we have decreased fatty tissue under our skin. We have some changes to our circulatory system, especially if we have people with diagnosis of diabetes, anything that will affect their peripheral circulation. Okay, and that's within our normal population. Okay, so if we think about diabetes, our population of children with lifelong disabilities aren't immune to some of these other general population diagnoses. And so it's such a surprise when we, all of a sudden have somebody that's entering adulthood and it's like, they have a diagnosis of diabetes now? How did that happen? That's not fair. They had a diagnosis of spina bifida. So there isn't a quota of diagnoses you can have, by the way, right? Okay. So we have to think about, with these integumentary changes, what that means for our population that's relatively immobile, and they tend to have a problem with obesity as they get older, or they're immobile physically and they don't have options of changing their position, and what happens to their skin as they get bigger and heavier too. In terms of musculoskeletal, lots of times we all develop back pain secondary to some of our disc changes as we get older. If we're inactive, or especially as women, we're at risk for osteoporosis. Osteoarthritis is very commonplace. In fact, as we get older, it's really not a, oh no, I have a diagnosis, but when are you going to be diagnosed with some form of osteoarthritis in some part of your body? We often have increased muscular stiffness secondary to some collagen deposits in our connective tissues. And when you think about then overlaying that on our population of children or adolescents with lifelong disabilities, one thing is they are oftentimes working really hard to move independently, and often they have abnormal forces, don't they? Their biomechanics aren't working the way yours and mine are. But we felt like, well, for function, that's okay. And we certainly wouldn't limit their function just because they weren't walking perfectly, but there are some trade-offs, aren't there? The other thing is that they tend to have more repetitive motions because they have a decreased repertoire of other motions available to them, and they almost always use abnormal biomechanics. So as a result, they end up with a lot of overuse syndromes. And as Lori said today, I'm going to touch on more, they have problems with pain. And how many of us really think about that? That's an orthopedic thing, right? I didn't go to school to be an orthopedic PT. I'm a pediatric PT. And somehow we think that, we're going to work on function and it hurts, but we're focused on function. It doesn't matter if they hurt, and it really does to them. And we just haven't connected some of those dots as a profession, I think. So in terms of our population, now coming back to that, okay, there are almost 400,000 18 to 21-year-olds enrolled in schools as of 2012 that were ready to transition out of school. So those are adolescents, right? Okay, so that's a big number. Compare that, or not compare, but in addition, okay, if you have Down syndrome, now at this point, you can probably expect to live to 60. Okay. Also, we know that people with these disabilities tend to develop age-related problems of pain, fatigue, and osteoporosis at younger ages than the normal population does because they're more sedentary, they're inactive, and they use abnormal body mechanics and abnormal movements. Okay. The other thing to think about, okay, with Down syndrome is, or not just Down syndrome, the persons with lifelong disabilities at the age over the age of 60 is predicted to double by the year 2030. That's huge, isn't it, when you think about it? So if you think about this almost 400,000 people between 18 and 21, okay, that's just a 3-year period, okay? So then think about the enormous amount of people that are going to be over 60 with these disorders by the year 2030. It's a little mind-boggling, and it really calls us to really think about maybe attending to some of these issues. Okay? The other thing is that there's over 500,000 adolescents with disabilities that are projected to needing to be transitioned from pediatric to adult services annually in the U.S. So that's also another big, big number. So we're not talking about just a few special cases here. We're talking about an increasing number of our population. Okay. So one of the things that's the key and that has contributed to having a longer lifespan is that we have more survival into adulthood of child onset conditions because we've made some advances in health care. Okay? If we go back to the example of my aunt, she was expected to pass away fairly soon, and let's put her somewhere, and we didn't have a whole lot of antibiotics, and these kids get sick, you know, she'll probably just pass away. Well, all of a sudden we've developed really good antibiotics, right? And we've developed a lot more medical technology that saves some of these kids, and we catch them earlier than we did. Okay? So often in infancy, we're correcting things like heart defects, right? We're correcting things like orthopedic things that we see on x-rays in infancy instead of seeing just how they play out. So we have made a lot of advances. Also, we have improved therapeutic and educational services for this population. You know, early intervention is mainstream. You know, people most often understand about early intervention. Maybe not all families have heard about it, but as therapists, that is really on our radar right up front. Okay? The other thing is that we've improved our technology. So there's more options now for people to be more active and engaged. Okay? Power mobility, augmentative communication. We also have a better handle on nutritional supplementation. So although power mobility and augmentative communication in and of itself are not survival kind of technologies, they do get people out in the community and get them engaged and give them a purpose, and they're not sitting at home necessarily just being sedentary. But you wanted to be a pediatric therapist, so why are we talking about all this, right? Okay. Well, one of the things is that as we know and are conscious of the fact that these kids are becoming adults and they just don't fall off the radar when they graduate from high school. Something happens, and we're more and more aware of there's just not a whole lot of options for them. And even sometimes through high school, we get frustrated because the team doesn't feel like they need as much therapy, okay? Or they're not in tune with the type of therapy they need. So one of the things that we need to think about is maybe there's a shift in our perspectives that have to happen with that, okay? They often have pain in their weight-bearing joints, okay? And that isn't just for the orthopedic therapist to deal with, okay? And I think they often have pain earlier than they're going to let us know. Okay, and we kind of get immune to the fact that they kind of complain about therapy, and sometimes we forget to really listen or start to ask them again every year what's wrong, because we think we know them, right? So as this pain creeps up, it's really good to really key into that as they get older and specifically ask about their pain levels. Often they can't tell us. Okay. we want to be keyed in on, we are such proponents of advancing function, right? That's what we do. We're working with kids, and we want to show that their function is improving every year. But as they get older and they approach adult sizes, sometimes what we're doing is fighting the loss of function because their bodies are bigger. They have more mass to have to control. The other thing we need to be keyed in on is that there's a need for modifications and compensations instead of skill development. And sometimes that's an emphasis that we need to really think about and be advocates for this group. We're going to talk about that in just a little bit too. Often, they also, as they get older, their episodes of care for outpatient, but also, I think, in schools, get shorter. They get less therapy per week or per month, right? And so they're sometimes at a point when they almost need more because their systems are changing, not more for skill development, but more for support in this change, they're really getting less. So when they're young, and if we want to look at this in terms of what we've talked about this morning in terms of ICF models, we could start off with, we're very conscious of their health condition, right? This is their diagnosis. You know, I have a child who has CP. I have a child on my caseload that has MD, right? We kind of frame what we're going to do with that diagnosis, even though sometimes we shouldn't, but it shapes our expectations, doesn't it, to some extent? Okay. So what we usually look at, often when they're younger, is we're looking at things like abnormal muscle tone, contractures, if they have a diagnosis such as Down syndrome or muscular dystrophy as it progresses, we're looking at their cardiopulmonary system. We're keyed in often on these kids develop low self-esteem because they can't participate with the other peers in preschool, right? We know that they may develop some overuse syndromes, and we kind of watch for that with those really on the extremes abnormal movements, okay? And we have some kids that seizures are on our radar too. But as they get older, okay, we're going to be more in tune to, wow, these kids might be more suspect or more susceptible to fractures, okay? They may have more of a chance of being osteoporotic because they aren't developing the weight bearing that you or I have, and that may show up at an earlier age. They're very prone for degenerative joint disease, obviously depression, obesity because they're sedentary. They're continuing to have overuse of their joints. They're developing pain, and as they get bigger, they're more prone to skin ulcers, right? And although we know this, okay, those are the things that tend to replace our concerns as they get older. These are things that should be more on our radar. Okay? And we know that, but sometimes we kind of miss that. So with cerebral palsy, even though we know it's non-progressive, okay, and we know that CP is a predominant childhood disorder, the evolution of that CP doesn't stop at 16 to 18. It continues because those individuals don't stop moving, right? So if they're walking with abnormal biomechanics and their knees are in excessive valgus, okay, we know that that's not going to stop. That's going to continue. And as it continues, they'll have knee problems, they'll have hip problems, they'll have ankle problems, they'll have back problems, okay? So we say neurologically it's non-progressive. They're not going to get more CP, right? But orthopedically it is very progressive for them. With Down syndrome, one of the things that we want to consider as they age are they often are prone to thyroid dysfunction. Okay. They have cardiovascular disorders that may or may not have been corrected. They tend to become obese. Okay. They have a lot of musculoskeletal disorders that not the same as CP, but similarly, they overuse some things that they like, movements they like. So they don't have the same amount of tone. They have low tone versus high tone, but they're still not moving normally. So they're overusing those abnormal movements. And we have, with this population, we have increased their lifespan to the point that now we know they tend to get Alzheimer's disease as they get older. That's kind of a cruel trick of fate, isn't it, with that? And we know there's a big problem with depression as this group gets older. Okay? So the cyclical process of this disability is that we have decreased muscle volume, spasticity, or low tone, okay? Orthopedic alignment deficits that leads us to having more muscle weakness because we're not using our muscles the right way. They're fatigued. They have a lack of activity. So that feeds into the fact that there's decreased opportunities to participate in activities, and that impacts a lot of the things they want to do and a lot of the life roles that they would like to assume. And this really could become cyclical, couldn't it? So the more you can't participate, the more you're going to have reduced muscle volume or decreased muscle volume. The more you're trying to move with abnormal movement patterns, the more you're going to try to pull in your spasticity to do what you can with it. Okay? So we can think of this also as a cycle. So when we think more about the secondary conditions as this population ages, okay, we want to look at some functional limitations. Like, as you're getting older, in the typical population, you want less people to help you. Okay? As these people get older, often they need a few more people to assist them to maintain their same level of function because they're bigger. Okay? We have limitations of mobility and difficulty using public transportation. And what that leads to is problems in participating in living independently. They have limited recreational activities. They have problems with social relationships because they can't be independently mobile. And if you're a teenager and you want to go out with your friends, the last person you want with you is your mom, right? My kids anyway. Okay? You feel isolated, and there's a huge underemployment rate with these individuals because people don't understand what they can do, or there's not enough support to allow them to maximize their abilities in an employment situation. Okay? So it's kind of a cascading effect when you get to participation. Okay? So what are the realities? Okay? So in reality, we tend to see this population of kids to adolescents have decreasing amount of health and rehab services, including PT, okay, in schools, but also out there in outpatient orthopedic situations. One of the reasons is it's hard for them to be transported sometimes. They have to rely on others to get them there. Another reason is that there's all of a sudden the school isn't covering that if they're not involved in school anymore, right? It's not part of their plan. And a lot of times they're limited in what kind of health care funding they have. So, and as we said before, the evolution of the effects of CP don't stop at 16 to 18 years. And also their motor performance starts to deteriorate after, once they get into adulthood. And we've talked about that with they're getting bigger, the demands are more, they're almost outstripping their compensations that they've used to be independent for so long. And many of them, for that reason, lose the ability to walk independently. Okay? And so I was thinking about that, thinking, gosh, as pediatric therapists, how many hours do we put into wanting to promote independent ambulation? How many goals do we write about independent ambulation, right? And then we know that the statistics out there are that a lot of these individuals will lose their skills to ambulate. That makes me feel kind of useless, actually. So one of the things that I think we need to think about in some ways is, do we need to adjust our mindset on that, okay? Do we need to provide some, maybe not say, well, hey, the stats say that you're going to lose this anyway, so let's not work on it, but rather to say, are there some alternatives we can give you so you have some choices of how you can be independently mobile? Okay. So with all these negativities about what happens to this group, been a Debbie Downer, haven't I? Okay. Let's look at some positives. As a profession, I think one of the things that I love the most about being a PT is that we are one of the positive messengers to our caseload about, look what you can do, right? We focus on, hey, you have this skill, and this skill. I'll bet you can do this next skill. So as we write goals, we're not the people that tend to limit people in goals. We're the ones that tend to push, right? I can see your skills. I can see your strengths. Let's build on that now to the next level. So I think that's one of the things that we can bring to the table with this population. Okay. The other thing is there's a mindset change as these individuals become adolescents. And it changes from We're seeking services not because of our medical diagnosis or the fact that we aren't keeping up with our peers, but we need to change it to we're seeking services because we want to have a way to meaningfully participate in our community and the things we want to do in life. And there's a change with that, isn't there? In another article that I was looking at, there's a shift in emphasis from the disability prevention, meaning, as pediatric therapists with younger kids, we're looking to prevent something, to slow down that process. We're looking to develop skills. So there's a shift from disability prevention to prevention of conditions that lead to activity and participation limitations. Okay? So there's a shift toward, the commonality is participation. What can we do to affect this person's ability to participate in the world in the way they want to? So on the national radar, if you look at the website for Healthy People 2020, there's 5 objectives that pertain to this population. Okay? One is that they would like to see the increase in proportion of youth with special health care needs who the provider has discussed transition planning from pediatric to adult health care services. And I would say that should include us. And we need to start doing it at a younger age. Where are you going? What are your therapy needs going to be after graduation versus, congratulations, you finished high school, best of luck to you. And then we let it go. Okay? They also want to reduce the proportion of adults with disabilities of over 18 years who experience physical program barriers that limit or prevent them from using available local health and wellness programs. And how this plays out is accessibility, transportation, support. Okay? So we can say, wow, it would be great if you could use the Y. But if the Y has a hard time with being wheelchair accessible, or it's hard to get a wheelchair through the equipment, that isn't a good answer for them. And a lot of times we've thought, oh yeah, maybe the Y would be a good answer, but we need to really look at the accessibility as well as how are they going to get there, and is there enough assistance available to help them access that equipment or to do what they want at the Y. Okay. The third thing is to increase the proportion of adults with disabilities that are over 18 who can participate in leisure, rec, social, or community activities. And that's where it's all about. That's the participation. That's our end game for this population. So we need to focus on a more independent-oriented therapeutic approach, okay? Meaning, what can we do to make you independent versus what can we do to get you to move more optimally, okay? Independence is where it's all at, and we need to really look at keeping in mind what's going to happen with their bodies as we're constructing our goals, okay? So what is mobility really, okay? Is it okay to have someone access some things in a chair versus pushing them to walk further, faster, farther when they're using abnormal movement patterns, okay, when they start to develop pain, okay? I think the other aspect of that we often don't think about is as little kids fall, we don't think anything of it, right? As you get older, and when you think about the tendency to develop osteoporosis earlier with abnormal alignment, a fall could be devastating for this population, couldn't it? And we tend not to have that on our radar either when they're younger. So there's a need for some health and wellness. Okay. This is, most teenagers would tell you they don't really care about health and wellness. Okay, but if you look at what the definition really is, most teenagers really are seeking that out. They're active, they're pursuing interests. Wellness doesn't involve just being physically fit. It involves friends, social participation, spiritual health. So it combines a lot of things, and as you're getting to be a teenager into adulthood, you're seeking out those things. Remember the whole idea of being independent and creating your own self-identity. So we want that for this population as well. The Healthy People 2020 objectives address some of this, but physical activity is also important to maintain a healthy body, and that's important for this population. It's not just it would be nice to, but we want them to be moving and to be moving comfortably for as long as possible, right? Not necessarily walking, but doing the things they need with movement. Okay? So the benefits of regular physical activity are increased bone health, reduce symptoms of depression, decrease levels of body fat, improve cardiorespiratory muscle fitness. Well, doesn't that fit them with these things that we say they're at risk for? So this is my only handout I've inserted, okay? But I wanted to give you some references of, there are 3 programs out there that are health-based curriculums. And remember, Lori talked this morning about curriculums, okay? So these are 3 programs that really look at health with people that have a disability. Okay? Living well with a disability is geared more for people that are a little higher cognitive functioning. Health Matters is geared more to people that have more cognitive deficits. But I wanted you to have those names because you can Google them and they're actually set curriculums where there's, and it's really, some of them are nice because they have a set pattern, like this is a 10-week course. Week 1, you're going to talk about this. Week 2, you're going to talk about this. Okay? I'll give people a chance to write that down. And I think that's a new development. I think that's something that we're, on a national basis, becoming more conscious of. As we've become more conscious of health for the rest of the population, I think this is a good thing. So if we want this population to be more active, and we're going to transition now from just the idea of wellness to actually health and fitness, okay, we need to remember that children in general have a lower anaerobic capacity than adults, okay, and it limits their ability to perform vigorous intensive activity, and that's for younger children. So generally for this population, we're not advocating a lot of clinical maximum exercise testing, okay, where you have the VO2 max, and because what their maximum is going to be different than what we see maximum as. They haven't had experience of having to exert themselves a lot of times, so we need to be very conscious of that. So what do we know? Well, we know that with this population, if we're looking at cardiopulmonary endurance, there's about a 14% decrease from normal values with this population. Some of the strategies we've used for kids to improve their cardiovascular endurance is putting kids on the treadmill, bicycling, aquatics, right? And what we see is that exercise on land and water, if you look at it in terms of, some studies have done 8-week programs with this, there's really no difference in perceived effort. So in some ways that's nice, isn't it? But they've also shown that you can make some differences without it becoming something that the kids think is way too overwhelming. Okay? The other thing is there's a 27 to 52, wow, that's a big range, isn't it? % decrease in muscle endurance, and that's based on different studies have shown different amounts of deficits compared to typically developing kids. Some common PT strategies that we've used are power training, strength training, again, aquatics, okay? And what we've seen is there's a decreased capacity to endure activities at similar loads compared to typicals. And that would make sense, right? They don't have that experience of having to use their muscles continuously. How many of us have ever really written goals about endurance? Okay? We talk about, I want you to hold your head up for so long for our lower functioning kids. And then we talk about distance of ambulation. Sometimes we talk about speed. Okay? But a lot of times we don't get into the, I want you to have continuous motion for 10 minutes. And a lot of our kids can't do that. They do it in spurts, don't they? We do this and then we stop a little bit. We do this and we stop a little bit. So that's something to consider. Okay? In terms of muscle strengthening, yes, we can strengthen people with abnormal muscle tone. Okay? But we know that compared to normal peers, again, this is a wide range, but they have a decrease of 34 to 60% compared to typically developing children. And we can use regular strength training and aquatics. Again, you see the common theme. Aquatics is kind of nice. Or circuit training. Often, our kids, as they get to be adolescents, they want to do what their peers are doing, what their typically developing peers are doing, right? So what are junior high and high school kids doing in the gym a lot of times if they're in sports? Their coaches have them come to the weight room, right? And they have to spend so much time on circuit training. So wouldn't it be motivating to set up a circuit training idea, right? So what they found in some of the studies is with a longer-term program, like 4 months, there's a decrease in perceived energy expended, meaning they feel it's easier to move. Okay, they're accommodating to that increased activity. And that's good news for us. That's helpful information for us. So some thoughts about exercising, okay? We know that for the typical population, that children, if we look at school-age children from 6 to 17 years, are physiologically able to adapt to endurance exercises. They do that on their own, don't they? They run and play and jump, and they try to do it better, and they do it more and more, and they try and try again, and sometimes they try till they're exhausted, okay? So the benefits of exercise are greater than the risk, right? In fact, we think that's good. But we know that with our kids that have some other overlying issues, that we want to make sure that there's some medical screening before we throw our population into some of this heavy-duty endurance work and where we're stressing their physiological system. So have you ever thought about taking blood pressures, right? Right? Looking at heart rates. You know, we need to be monitoring them once we get clearance about how is their system physiologically handling this increased workload that we're putting on them. Okay? So how we apply this to typical populations, okay, is a lot of times we're using some theories. One is the health behavior theory and the trans-theoretical model, which says, you know what, you're kind of sedentary. What kind of things would you like, and when would you be ready to go to the gym? We don't, to be successful, we often don't just put them in the gym and say, you do this. For them to take it on themselves, they have to be kind of convinced this is something that they want and they want to change. Okay? So we can apply that to our population. Okay? It's important that these kids feel that they are developing self-efficacy, meaning that they are part of the decision, that this is something that's, again, remember, helping them develop their own self-identity. Okay? So we need to think about the importance of self-efficacy as we look at this. Okay? Now, transitioning to our experience, we are really good at giving instruction on home exercise programs, right? That's what we do. We're perfect at it, right? But we aren't often as good as having those conversations about health and wellness, okay? You know what? You're sitting a lot. Maybe we need to get you to be more active. What do you think about that? Okay? We're often the architects of the program, and we're telling people what to do. Okay? So what we need to do is to connect some of this with students with lifelong disabilities and see how it would look like with our child that perhaps has CP. Okay? So are there things that they might want to do that would make them healthier? Okay? A lot of times they already have opinions about this. Okay? I don't feel good, I hurt, it's better when I move, but I need someone to help me move. And so we start having those conversations on that level. So currently, do you like this picture? This looks like my kids. Children over the age of 10 do not meet, in general, the recommended physical activity guidelines. Okay? In fact, I have a colleague in the RHP program that her dissertation topic is looking at schools and how much activities are in schools and correlating that with BMIs and looking at the fitness level of school-age children. Okay? So when you look at our typical population not getting the recommended physical activity guidelines, our population for sure isn't either, right? So, but children and adolescents who are typical have the ability to participate in a variety of age-appropriate physical activities to help develop their cardiorespiratory, bone density health type activities. And oftentimes we stop short of providing our population with those kind of activities. Okay. So what are the guidelines for fitness? Well, there's a certain amount of frequency that you need to be active at a certain intensity over a certain amount of time and a certain type of exercise. Okay? So we're going to go through those quickly. So you need to be fit. You need to have aerobic exercise at least daily. Moderate to vigorous intensity 3 days a week. Okay? You want to see a noticeable increase in heart rate and breathing. Okay? And you want to have that normal kids should aim for about an hour a day, right? So things that are enjoyable, developmentally appropriate, running, swimming, jumping, briskly walking, dancing, bicycling, those type of things that get their heart rate up, okay? For strengthening, you want to be able to, ideally, we want to see kids do some strengthening type of exercises more than 3 days a week as part of their 60 minutes of physical activity. Okay? We want to look at things that are unstructured. We're not saying that kids should be bodybuilding and pumping iron, but things they do normally, climbing trees, okay, playing on playground equipment, doing tug of war, wrestling with each other, right? Okay? Or if you have older kids that are wanting to be more structured, like the junior high and high school kids, the lifting weights, working with resistance bands. Okay? Then for our population too, bone strengthening exercises. No more than 3 days a week, also as part of that 60 minutes per day. What we want to look at are things like loading exercises, weight bearing, jumping rope, basketball, tennis, resistance training, hopscotch, those type of things, okay, where we're loading and unloading our lower extremities. Okay. So then we're going to talk a little bit now about, the other thing I was going to tell you is that information I got that from the American College of Sports Medicine's Guidelines for Exercise Testing and Prescriptions, which most of us as pediatric therapists wouldn't think applied. But there is a whole section on people with disabilities in that. So don't be afraid to tiptoe into other people's areas. That's a great resource, okay? It doesn't just pertain to people who are who do not have diagnoses, okay? And that's been a real helpful guideline. It also is helpful because it walks you between, yep, this is what the expectation is for typically developing children, but also with populations with this or that diagnosis, here's how you might want to modify it, and here would be some expectations. So I found it really exciting that that's represented in that book. It's called the American College of Sports Medicine's Guidelines for Exercise Testing and Prescription. So I'm going to go back to this idea. Lori did a great job of talking about the different assessment tools. Okay, and what I did, we did not collaborate on this at all, but I was really glad that she gave you this range. What I have for you are those assessment tools. I lifted out the ones that I felt pertain to older children and adolescents. Okay, so these are the ones that go up to 14 to adulthood. Okay, they may start younger. And some of those that has talked about. One of the things, the Skills for the Growing Up tool, has been developed and modified for kids who are at end-stage renal failure. Okay, so it's more of a very ill, medically fragile type of population, and we sometimes have those. Might not be because of renal failure, but I thought that was useful because I think we can kind of feel sometimes like those activity participation scales, quality of life scales, really pertain to people that are actively out there participating. And we don't have, all of our kids are not like that. There's some that are very medically fragile. And that's the Skills for Growing Up kit. The ASK, okay, I think she talked about that. It assesses the physical and their capability. Okay. The Life H, again, is the one that assesses quality of social participation, and it looks at ADL and social roles, too. So some of these are nice because they give you a bigger bang for your buck. So you're looking at participation, but you're also looking at it in the context of ADL skills and skill development. Okay. And I think all of the other ones are ones that she had talked about, but we need to think about some of the ones she talked about that I didn't know about, like the Energy Efficiency Expenditure Index. That would be great for us, wouldn't it, with this population, especially as we're trying to ramp up the intensity of what we're having them do. The thing about assessment tools that I think needs to be highlighted is assessment tools, we want to look at them not just with the range of ages that they're for, but how does that affect the level of our client or individual, right? So if we have a cognitively low functioning individual, that may be a different assessment, even though they're the same age, as another one that's geared more for people that can participate more and have higher cognitive functioning. So that's something to keep in mind too. Don't just pick an assessment tool because it matches an age. Really look at if it will give you the information that you want it to give you. Okay. One of the things that I wanted to highlight about the CAPE, between the CAPE and the PAC, is the CAPE talks about what can you do? What are your capabilities? The PAC talks about, but what do you want to do? And I think that's really important to us too in terms of motivating this population. So another thing that I have lifted from the American College of Sports Medicine is they have a different classification system for participation in sports when they're looking at guidelines for participation in sports. And I want to run through this. There's 8 levels. I'll go through some of them quick. But the thing that we need to know is it's an opposite scale from the gross motor classification system. So 1 is the people that are more involved. Okay? And then 8 are the people that are minimally involved. And that's a flip. Okay? So they have defined for you indications for, in terms of Class 1, you're a power wheelchair user, you can't functionally propel a manual wheelchair, you have poor functional strength and range of motion. Class 2, you're a little bit better, you may be athetoid, you're able to propel a chair though, and you can have some rhythmic movement when you're swimming. Okay, so it kind of gives you some ideas of maybe what activities they might be successful at. Okay. Class 3, as a wheelchair user in most instances, but you can propel it independently. You can walk short distances with an assistive device. You have better trunk control than if you're Class 1 or 2. And you have but you have some limiting spasticity in your shoulders and arms and fingers. Okay. So Class 4, you're a little more functional. Okay. So Class 4, one of the biggest differences is that you're a wheelchair user in most instances, and 4 is your wheelchair is usually the athlete's choice for sport. Okay, so you can do a little more, and you're using your wheelchair to allow you to participate in something you want to do versus being kind of dependent on your wheelchair for mobility. Okay, you have upper extremities that show moderate strength. There's minimal limitation in your range of motion. So then in 5, okay, you can ambulate and you're often able to run. Okay, so this could be our kids with diplegia or our adolescents with diplegia. Okay, you've got symmetrical shoulder girdle function. Okay, in Class 6, you can ambulate without an assistive device. So see the progression, and I like the fact that it really defines some of the fine-tuning of this progression too. Okay, Class 6 athletes have more control problems. Okay. But they're starting to refer to them more as athletes. So here's the last 2. What I think is hilarious about this is they say, okay, you're ambulatory without assistive devices, so it's making a case where you're less and less disabled, you have more skills, good functional control on the dominant side, you may have some asymmetries. But look at Class 8. Must have obvious impairment. So they still want to make sure that you're not cheating, we're not slipping someone in this category that shouldn't be. You know, they're wanting to make sure, okay, this is still somebody that we know has CP. But I think that's helpful to us in terms of looking at some participation things. So, for example, some of the things we want to really make sure is that because these individuals haven't had exposure to or work on a lot of the cardiorespiratory system, what we perceive as minimal effort may be maximal effort for them. And we need to be really in tune to that and really ramp down our expectations. They can have increased oxygen demands more than we think, more than we would have, because they haven't had conditioning. Okay. Also, we have individuals that have muscle spasms, right? They don't have good breath control. They don't have good control over their swallowing. Okay. They have a gag. So think about that as you're having them work harder. So it's a both ends of the stick, isn't it? We want them to work harder because they haven't had those experiences, yet these are some things we really need to be aware of. You know, we don't want to push them over the edge and have them aspirate on their saliva because we just felt they should walk faster and work harder. So I had this patient, it's the same one that called about the fire in her garage, right? And I decided she really, in her school, they were about to take away her goal for walking in school because it took a lot of people to help her. And we had a light gate in our facility. So I put her in the light gate, okay, and I put her on the treadmill, and we decided, let's walk, let's see how fast you can walk. And pretty soon she looks at me, she says, my arm is wet. What is that? Well, sweetie, you're sweating. She hadn't ever had that experience before. And I think that's true for a lot of our kids. They don't know what sweating looks like. And now there's some more evidence that it's okay to sweat. In fact, we want you to sweat. But our kids, we don't ever get them to that point. And that's something we need to think about. But as we do that for the first time, they're going to think there's something really wrong, isn't there? My arm is wet. So some specifics, okay? Maybe we want to think about, and I'm giving you these things in general because we know all of our individuals on our caseload are very individual, okay? But ergonometry, in terms of upper and lower extremity ergonometry, a stationary bike, a hand-operated ergonometer, are really great for our kids with athetosis because they can be stabilized and they don't have to control all their body. They can just control part of their body. So one of the biggest challenges, I think, for increased endurance and strengthening is there's a lot of them to control when they don't have control themselves. So if you can limit what they have to control and just concentrate on one area, you can get at that working hard part of the things we want to do, okay? Wheelchair ergonometry is recommended for individuals with moderate involvement, the classes 3 and 4, okay, who have good functional strength. You can get someone to work pretty hard at propelling a wheelchair, can't you? And you could have races, okay? You could have beat the clock for yourself, okay? You could have competitions. You could have a chart where, you know, I want to see by the end of the week, how do you think you can get here in 5 minutes? The next week you think you can get here in 4 minutes, okay? So we can build some fitness kind of things into their everyday routine as well. So for those individuals that are class 5 to 8, meaning 8, you still have to show that you have a little disability, right? Okay. We can look at treadmill testing, okay? You want to watch for fatigue because what happens to our population as they fatigue? What happens with, like, if we have someone that has spastic diplegia and they fatigue, what happens at their ankles often? A little drag, a little foot drag. So we want them to be safe in these situations as well. Okay? So we can do that, but we need to watch for deteriorating function and for their safety. Okay? We want to make sure that we've done a functional assessment including strength, range of motion, flexibility, balance. If we're going to ask them to work on a stationary bike, we need to make sure they have the range to work on a stationary bike, right? They have to have hip range. They have to have knee range. They have to have ankle range. And if they're in AFOs, you need to watch what happens when you put them in a pedal and you lock them into a pedal. Okay? You want to promote the use of adaptive equipment and harness and strapping for safety, but the harnessing and strapping shouldn't block them from moving, or else they get frustrated and they're moving against an external force, and that can really cause damage to their joints as well. Okay. So the bottom line, okay, is that exercise improves their health-related components, okay, and that's something that I think we've been missing, okay, in our therapies. And so we want them to not just do exercise for the sake of let's improve your hip abductors, but exercise to improve their whole system, their cardiovascular system, their overall strength, their fitness, okay. And so we want to look at that relationship between those FIT principles, meaning frequency, intensity, time, and task, and associated long and short-term goals and improvement. But we know that there's not a lot out there that tells us where to go with that. So that's still kind of an open frontier. But what I think we need to do is try and make sure we're monitoring these people physiologically for safety, meaning looking at blood pressure, looking at the response to exercise, monitoring respiration rate, pulse rate, things like that, okay? So I wanted to talk a little bit about some other outcome measures for older kids, because as we're looking at, we want something to do that's meaningful to them and participate, we still need to measure it, know where we're starting and know where we're heading, right? And also it kind of justifies why we're involved in some ways, okay? So that's how we're going to know we're making gains. So some of the things I picked out are things that are geared in their range toward older kids. But again, you have to look at that individual's skills, okay? So for example, I know that Lori asked how many people were familiar with the BOT, but how many people here are familiar with the BOT? Most of us? Well, you know, we're never going to get anyone who's really pretty motorically involved to even score on the radar on the BOT, right? You have to have a certain baseline of abilities. So we're going to waste a lot of time if we say, oh, wow, great, the BOT is for kids up to 14.5 years, but they can't do the first thing on it, okay? So we need to think about that. The GMFM, on the other hand, it can give you some great scores and great baselines for kids that are pretty motorically involved, but you can ceiling out of that really fast too. So if you have a child that can stand independently, that is really independent at moving between positions, there's not going to be anything left to work on, right? So you want to pick your assessment tool accurately. I want to talk about just a couple of these. The ASK goes up to 15 years. Okay. This is for kids with musculoskeletal limitations. It's a self-reported measure. So, and it also measures what the kid did do and what they can do. Okay? So there's a difference sometimes for our kids. And so what we want to tap into is, okay, it's good that you did it, but look at what you can do. So I think helps to give us a little map of where we're going next with it and what we can really push them to do. The COMPS, which is different than the COPM, right? Even though it's got all the same letters, but in different orders, right? This screens for subtle coordination problems. So this wouldn't be the one to use on kids that are more motorically involved, okay? This is for those subtle, man, you're still looking goofy. I still can't quite figure out where I want to go with you. It may give you some direction with that, okay? It looks at slow movements, arm rotation, finger, nose touching, some of those things that are more precise. And the GMFM, again on the other end of the scale, okay, looks more at postures and how you move within the postures or how you can assume the postures. The PANIS is for school-age children. It can be used to demonstrate change over time. It's nice because there isn't much equipment that you need for it. And it measures, it really is for a little bit higher functioning kid looking at lateral preferences of hand and foot, eye preference, stress gait, heel-toe walking, balance, motor persistence. So you have to have an ambulatory child for this, don't you? And this, the top age is 11, but again, as Lori said, a lot of times I'll use a test that maybe has a lower age than my child actually is if I can get them to fit, and then it gives me something to measure too with that. Okay, so this is norm reference. Okay, and this is nice because it identifies or helps you with some of the ferreting out some of the things with kids who are significantly behind their peers. Okay, and a new version should have been out next or last spring, and I haven't checked, but it's coming out of U of M. So they're looking at updating this too, which is kind of nice that people are always looking at things to improve them. So the other thing is we should all put on our radar is I thought the PODC that Lori talked about, the Pediatric Outcomes Data Collection Instrument, was kind of cool. That was the one she said there was a list of things that it looked at. Some were sports functioning, pain and comfort, global function, satisfaction with symptoms, and happiness. Remember her talking about that? Who measures happiness? I think that would be perfect for a lot of our kids, okay, especially as we want them to become more autonomous. Okay? So some outcome measures for balance, okay? Let's not be afraid to dip into some other types of testing, okay? There's pediatric measures for balance, and then often, and the BOT has a subsection for balance, right? But often our kids outstrip those tests. So as our kids are becoming adults, let's look at adult balance testing. right? Let's not be afraid to say, hey, wait, they're almost adults. Let's pull from that pool of things, too. And that's where I think we can collaborate with some of our colleagues that are working with adults with balance disorders. A lot of times, even the things that have been modified for kids, they may ceiling out of, and we may need to move on to the next type of test with that. Things like the pediatric reach test. There's some assessments that are real easy, aren't they? Okay, you need a yardstick for this. Okay, and what it's going to measure is not only can you reach, but how much control do you have when you reach. Okay, allows you to test this in sitting. Okay, so you can use it for kids with motoric involvement. Because remember, if we're going to go back to the idea of, well, they may lose their ambulation skills, how much can we stabilize them to give them more options for independent mobility with less and less postural control or support they need in like a chair for movement or some other kind of a device. Okay. The pediatric balance scale is a modification of the Berg balance scale. You can use it for screening. Okay, you can look at sit-to-stand transfers, sitting, standing unsupported, standing with eyes closed. Okay, a lot of times those are really important components of the things they want to be able to do to participate. I want to go with my friends to a restaurant. Well, think about all the complexities of getting to a restaurant, and you have to get between tables, and you have to pull out chairs, and you often have to go behind people who are already seating. So some of these things will be able, if you start to analyze what's involved in those tasks, some of these assessments can be a really nice way of documenting that as well. So do you remember the old foam and dome? Remember learning about the foam and dome? This is an adaptation of foam and dome, okay? So what we're looking at is what part of their system are they using primarily for balance, okay? Is it that they're dependent on their vision? Are they dependent on their vestibular system? Can they keep their balance when we take away reliable proprioception? Okay, so don't be afraid to reach back to some of those things we learned and that we thought were just adult type of things. We can still apply those to our adolescents because they're almost adults. Okay. There's a community balance and mobility scale that I haven't used, but I think this is intriguing. It talks about 13 challenging tasks that are performed on a more functional community type basis. They want those tasks to be performed without assistive devices, but you can still use orthotics, which is really helpful to our population because most of them have orthotics in one form or another. Okay. Some of the outcome measures for functional mobility, timed up and go on stairs. Some of the things that we can look at for measuring endurance, a 6-minute walk test, a 3-minute walk test if they can't do 6 minutes. You can go from, they top out on the 3 minutes, you know you're ready to move to the 6-minute walk test. Is that correct? So you can look at then that distance per time, okay? So you can up the stakes in terms of a distance or intensity by saying, okay, you can now walk independently from your classroom to the library. Let's see if you can do it in 30 seconds less, okay? So, and you can even look at dividing that distance and looking at kind of like splits if you're running a cross-country race, right? How many people ran cross-country? You know, splits, you did this in the mile. This. So you can even break that up, and you can even make it kind of a big deal, kind of like an event for them, too. The WeFIM is a functional independent measure for kids. That's a great test in terms of looking at overall function, but it's very prescriptive, and you have to do it exactly the way and score it exactly the way that it's laid out. And sometimes in real life, that doesn't work for our situation. So it's something that you want to look at and see if that would fit where you want it to be. Sorry about that. I talked and should have been advancing this. Okay. So some of the things we're going to have to do maybe is we might have to change our minds about what we expect for this population. We might have to change our perspectives of what they could do and our expectations for them. I think often the case is that if we improve or increase our expectations, those kids will fall in line a little bit too. Okay. Some of the kids that I've had the most success with are from families, and you probably have too, families that have had big expectations for their children. I have a friend who's a social worker. She's the mom of 2 kids. She walks with sticks with bicycle handles on them. She has, by the way, a diagnosis of spastic diplegic CP, okay? And she will tell you, I hated my dad because every night after homework, I had to walk across the kitchen so many times. She said, but you know what? I would not have been where I am if he hadn't have done that at an early age. And often we have to help parents feel okay about that, having those expectations. If we are the only ones with the expectations, it probably doesn't do much. But if we infuse and empower parents to have those expectations and provide them, I think we're good at this, provide them with other success stories of other families, that's really helpful to them too. And for them to feel okay about, your kid can be mad at you, that's okay. You know, that's what parents are for, right? We're not here to make our kids happy. We're here to make them work. Right, Sophia? So anyway, it may be just kind of looking at one of the first steps, maybe just empowering families to have more expectations and then providing them with some ideas and some supports to gain those ideas or to gain those skills. Okay? So kind of in summary, okay, we want to look at these services for this population of older kids and adolescents with kind of an entire life perspective. We need to know where they're headed, okay, in terms of both school, job, but also health, right? We need to keep activity and participation factors in mind because that's where we really want them to end up, is being able to participate to the best of their abilities. We want them to be a part of it and to feel like they're determining what they need in life, okay? But as therapists, we also want it, because we're always going to be therapists and think this in the back of our minds, right? How can we impact some of those secondary complications they may be headed for early on and maybe delay them or even ideally prevent them, okay? And also, this is the time to do still some collaboration with adaptive, physical ed, community therapists as they cross over from pediatric settings to adult settings, rec resources out in the community. There's more and more this is getting to be a population that is on people's radar in terms of recreation, leisure, and so it's good to know what programs are popping up, what facilities can accommodate this population. Sometimes as advocates, we're the ones that kind of nudge people into opening the door for them. I have a child that wants to participate in gymnastics. Can you just give this a try? I think they could do this. I think sometimes in the community, people are put off the minute they hear a diagnosis. Sometimes we have to be the ones that hold the hand of that community person and say, it'll be okay. You're going to be okay. And the family will still pay for the service, but could you just let them try? So I think we help to open doors sometimes with that. Some of the sports activities that may be appropriate for our caseload, depending on their function again, is swimming is a great sport. Did you see all the things about aquatics up there? Muscle endurance, muscle strength, cardiovascular fitness, okay? Running, okay? Even maybe modified running on a treadmill if they're able to with some support, okay? Canoeing, you don't have to use both your upper and lower extremities in a canoe, okay? So if their family is going to canoe, encourage their family to let them paddle a little bit. Think about what that does for their trunk, okay? Skating. There's skates that can be locked out so they don't have as many degrees of freedom, right? Skating's not for everyone, okay? Bicycling, be it with their own bike. There are adaptive bikes out there. I'm part of a group of Bluegrass Ambucks that the idea is to provide bikes for kids with special needs with a lot of adaptations, but there's other ways of doing that, and there's other companies out there that do that. So bicycling is good, and there's a lot of things that can be put on a bike to make it accessible and successful for kids with a lot of different disability levels. Skiing in Ohio, there's a organization called TASH that does some adapted skiing. They sometimes they do partner skiing, sometimes they have special adapted sleds that you don't have to control as much of your body. They don't just put kids on the top of a hill and say go to town, okay? But skiing isn't an out of the way idea with adaptation, okay? Rollerblading, okay? Things like dance. There's a lot of in the area of modified dance classes, okay? Martial arts is a great way to build up endurance, strength overall. It's good for us, right? Gymnastics. using the Wii or some kind of an electronic game, okay? The thing with the Wii is it's got lots of flexibility for lots of activities, but who's familiar with the Wii? Okay, what happens if you don't meet the minimum bar? What does the Mii do? He frowns and goes, "Ooh." So sometimes my problem with that is, and I wish I could turn off that function of it, is you get a kid that starts with, let's say for the soccer game. Remember the soccer game where they're heading the soccer ball and the shoes are flying at them and whatever else. So you get a kid that starts here, this baseline level, and they get like 5 more. But they're still not at the point of, yay! So even though they improve, at the end the Mii still goes, ooh. And it's like, no, that's sad. You're right. So an active video gaming. You know, a lot of times, you know, we say, oh, we don't want our kids to play a lot of video games. And we don't as their only activity. But if they're able to participate in that, and you can have them do it with less and less support, that certainly is working on their trunk, right? They're engaged. They're really on their own in terms of weight shift, and they're feeling very independent with a hobby. Okay. So I wanted to take some time and talk about what is your experience that we can share as a group. Has this been on people's radar a little bit? No. What are your successes? Say it. 425.
I don't have one as a PT, but I have a nephew with Down syndrome who's 15 and in high school. And right now he's swimming with his high school team, getting up and practicing at 5:45 every morning, just like everyone else. And he's increased his speeds this year. There's been right up on the paper.
That's great.
Really cool.
Yeah. So what did that take for him to do that? Did someone have to open the door for him, or?
It took his parents really advocating for him.
Yeah.
And it took the coach buying in and being willing. My brother's coached the Special Olympics a lot, his dad has, and so he was there, I think, kind of be a support initially.
Mm-hmm. Mm-hmm. Very cool.
Yeah.
Someone else over here? Has this given you some ideas or directions, ways to justify it in terms of school? Okay. Because we don't want this to start after graduation. We want this to start the conversations and the ideas and the plan to be in place as they're getting to be adolescents. So, does anybody have any questions? No? Well, thank you so much for your attention.
Thank you.
Hey, thanks.
In fact, I have one of your students.
Tell me your name.
I'm Amy Monday.
Oh, Amy, okay.
I'm an outpatient.
Are you
In Mount Starling, I have one at Lake.
Oh, yes.
I
Okay.
can take you one help. So I see him later on. So.
Good.
Thank
Thank
you.
you so much. Thanks for you. I saw you nodding and things.
Is there a place to go to find out what tests you all have available through the lending library?
Let's have Susan. Hey, Susan, is there the lending library for the assessment tools? How do they access
You have
that?
to either email myself or Dr. Schnick.
Okay, who's Dr. Schnick?
EKU.
EKU. So it's on the paperwork. I have your email.
Somewhere, or you definitely have Heather Forrest.
Yeah,
Foster.
Heather Foster.
We definitely have her, and she's probably a better person anyway, because she can track it down
All
for
right,
you.
so they're either here or at EKU, depending
It depends on where things are at any given time. More likely PT stuff here, more likely OT there, but
It's hard to say.
yeah, so
Okay.
get through to one of us.
That's the first in, and then they'll find it.
Yeah, then we'll find it. I mean, that's
And
it.
then,
We
like,
have
just,
it.
I had a kid, a high school kid, and just trying, when we were doing his 3-year evaluation, I'm like, he presents like CP, he has Mobius syndrome. He presents a little bit like CP. He has the vision stuff. The GMF film is for 5-year-olds.
Right.
And I'm like, we're kind of past that, to compare to
It can go up.
just to give me some information.
Right.
on what he's
Ambulatory?
doing. He is. So what I ended up doing, I looked at the standing walk obstacle course, but finding the parameters on how to administer that was like, even like the timed up and down. Like,
Yeah.
I couldn't find, like I could do it, and I had the parameters on how to do it, but then I
Movement
didn't get the
AB.
information to tell me
Movement
the
ABC. Movement ABC, and it's something you can borrow from us if you like.
But like at that age, I have you. At that age, you would have to hop on one foot. You can't do that.
Yeah, but the movement ABC is lower than the Brunik-Sozereski.
But even I think at his age, for the 11 to 16, you have to hop on one foot. Yeah, and I know he can't do that at all.
Are you familiar with rehabmeasures.org? It's a website, and it lists like 200 assessment
Okay,
tests.
because
And it
I could
talks
find
about
like the journal
Stuff
articles.
too, because that's all now in the journals.
Okay.
Well, that's recently been published.
I mean, like I could find like all the different balance tests, but finding all the parameters on how to administer it was very difficult. Or it would just send me back. I'm like going through, 1995. Where I got those journals stored somewhere.
Or you can purchase this for $1,000.
And I
Yeah.
can't. As far as like with him, he's one actually at the cadre yesterday. I got Joyce's name to refer him because Mom came up to me, hey, I'd like to get this bike for him. I said, wait.
Joyce is a
your
good friend of mine.
Well, and it's so funny because she actually grew up down the road from me because she's
Really?
from Mount Sterling.
She and I were business partners.
Oh, okay. Well, she was from Mount. She worked with
Yeah,
my
that's
mom
so
was the
cool.
office manager in rehab years ago when she worked in Mount
It's
Sterling.
such a small world,
So she's
isn't
like,
it?
she said, would Juanita by chance be his grandmother? I'm like, yeah. She said, I know who they are. I said, okay, well, that'll be good. So I'm going to go back and give Mom her
And then
contact information.
Marty is her sister. Marty Ginsburg is her sister.
Oh, is Joyce's sister? Yeah. I had no idea.
See, everybody's just interrelated
Yes,
around
they
here.
are. I had no idea. And
We'll talk to you. Hey, thank you.
but let me write that down.
Okay.
Rehabmeasures.org. And you seem like you know a lot about this assessment, so it's sitting behind you in Lori's lecture.
We try. We try. Well, the biggest complaint that I have, this mom is very much, he's like, actually, hopefully they'll meet next week and get him into the school for the blind. Because he needs to go, and she's talking about, he's 19, having him placed on homebound and not really coming to school next year, and that we would continue because we've made some modifications in the FMD classroom, but that's not like, she's talking about getting either a granny pod or a little apartment at the end of their trailer, so we can go in and do the functional stuff at his home. Because he does have, in his progressive vision, he has, like I said, he has the Mobius syndrome. But he's very motivated. Like, he fried an egg for us. It was Dr. Seuss week, and we do preschool through high school. But we're doing green eggs and ham, gack and flipping and doing this stuff in preschool. I said, what are we going to do tomorrow at the high school? She said, I said, we could cook an egg. So I'm calling her in a route going, hey, I'm going to stop and buy bread. I'm going to make him toast it and do a whole sandwich, the whole sequencing of it kind of thing. And he did awesome with it. He really did. So, and then like the VI teacher comes in, I'm like, this is what we had him do. We may have been wrong on that, and where's O&M? We did what we thought was best, but we could have, we might have told him some wrong stuff. I don't know. So we had Masters Carrie Covington. I need to get on your to take a student.
Yeah.
And I didn't, at the evidence-based research, they gave me your name, I believe, and I just never pursued. That's okay. Do it at rehab.com or org?
Rehabmeasures.org.
Org, okay. All right, and then you said Heather Foster.
Yes.
Okay, or Susan. And this, is she through EKU, Heather?
Heather's through EKU, Susan through
Susan's
UK.
here, yeah. All right, and you're here.
I'm
Okay.
here. Yep.
And then, do I have your name somewhere? I think it's on the back of this right here. Is that, what's your email then?
Here, let me write it for you.
Yeah.
Sometimes it's just easier.
I actually work for Covington Therapy Services, which is me and me alone. But then
Oh, yeah?
to Montgomery County Schools. But I have 74 kids on my caseload, so I mean, I'd have lots of stuff.
Yeah.
I said it just makes you have to work harder too. And that's what I'm halfway afraid of.
Yes, I know.
Maybe so. I don't even.
Well,
know how-
maybe just that first, like you think, oh gosh, this is going to be forever. Working hard at this. And then,
Yeah. Well, I worked. ARG had the contract for the hospital and the schools,
Yeah.
so I still did the schools. And so when they would have a student, they'd come with me 1 or 2 days a
Yeah.
week if they were interested in PEDS.
Yeah.
I did first steps then, and I don't do that now. Just the schools. But what are their how do their clinicals work now?
So they
Is it like
have.
a 3-week or 4-week, or is it still 6 weeks?
I'm still
and then
doing faculty. The second years, they were, for the first 9 weeks of the semester, 8 weeks, they went 1 day a week.
Okay.
And now they're going to be out for 9 weeks.
Okay.
in a
Well,
couple
that
of
might be
weeks.
more beneficial for me to start
And
with
that's
a 1 day a week
full-time,
one.
but
and
it's
then-
like a January through mid-March, just 1
Which
day a
would
week.
get, and hopefully, I don't know, I mean, I'm sure they pick the day, and like
Let me
this,
give you the name of the person to contact. too.
this winter was awesome because we didn't miss that much
Can I
school.
write on your? Can I write on
Yes,
your?
go
Yeah, I
ahead.
know it was a great winter.
You know, so we haven't missed that much school. That's the thing, you know, if they just need their 1 day, there would be times, oh, we don't have school today, or oh, we're 2 hour delay, or there's no school for flu, or whatever. But just to kind of, I had students